Welcome to the afternoon session of the collaborative. So my name is Dax Bourcier. I'm one of the co-leads for the Health Workforce Planning with the Canadian Health Workforce Network. And I am very excited to present to you the topic that has the potential to transform healthcare as we know it. So we're going to dive into health forecasting models today, and really in terms of how cutting edge technology and predictive analytics can really change the future of healthcare and allow it to become efficient, personalized, and proactive. So the focus of this panel will really be in terms of health workforce forecasting models, as well as how they relate to workforce planning specifically. So we have a great panel of global leaders here today. They're going to have a chance to present some of their work as well in small presentations and answer some questions that I've come up with. And then we'll have about 15 to 20 minutes for audience question and answer. And so without further ado, I'd like to present you the panel. So first we'll present the people who are in person. So to my left, we have Sarah Simkin. So Sarah is a family practitioner and anesthetist and the health workforce researcher. She is the health workforce planning co-lead also for the Canadian Health Workforce Network. And she's also been co-leading the integrated primary care workforce planning in Toronto since 2017. And she's been doing this with Cynthia Damba as well. And she is online. Cynthia is the director of the health analytics team at Ontario Health, Toronto. She's trained as a physician as well as epidemiologist with planning experience in population health, health equity, primary care, healthcare system measurement, and quality. And she's been co-leading, like I mentioned, the primary care workforce project in collaboration with the Canadian Health Workforce Network. Also in person, we have Steve Holloway. He's from Colorado in the United States. So Steve Holloway is an experienced public health professional, professor, and board member, serving organizations with a public and community health focus. He's currently serving as the director of health access branch at the Colorado Department of Public Health and Environment, position he's held since October 2011. Additionally, he's an adjunct professor at the Graduate School of Social Work at the University of Denver, where he teaches courses on mental health and substance use policy, social determinants of health, and public policy. He's also working on big data and how that helps in terms of workforce planning, retention, and recruitment in Colorado. Online, we also have Colin Tilley. Colin, and I realized I should have probably asked Cynthia to wave. At one point when I introduced you, I didn't quite, you were not on the screen here, so perfect. And then Colin, who's also online, if you can wave, excellent. So Colin is from the United Kingdom in NHS Scotland. He's the head of the program with NHS Education for Scotland, which is an education and training body and a national head board within NHS Scotland, responsible for developing and delivering healthcare education and training for the NSH, health and social care sector, and other public bodies. Colin will be contributing towards the NSH Education for Scotland's focus for 2023-2026, which includes improving the range, quality, detail, analysis, and reporting of workforce data linked to population health and care needs. And lastly, we will have a video recording from Nick Lord, who is the National Director of Engagement and Government Relations and Australia Health and Practitioner Regulation Agency. Without further ado, let's dive into some of the questions. So the first question, in the past decades, at least in Canada for sure, we've seen a shift in terms of forecasting models from supply-based to more needs-based, population-adjusted needs-based, as well as mixed models at once. And these models are often dynamic, allowing for simulations based on specific scenarios to be possible. However, with all of these models, there's still no gold standard. So my question to the panelists is, why is this the case? And how close are today's forecasting models from estimating reality? So I will open it to the panel. I don't want to pick on anybody. If anybody would like to go first, please just go ahead.
I guess since I requested the microphone, that must mean I'm to go first.
Excellent.
I was sitting here thinking this morning, if I had the choice between a really efficient model or really pristine data, I would choose really pristine data. I think poor models with excellent data are more informative than excellent models with poor data. And so I think certainly from the perspective of the United States, most of the kind of work we do is sort of based in a health professional shortage area model. It's in federal regulation because regulation is so difficult to change. That particular model has really not moved much since 1977. Of course, the care delivery models, the needs of the populations have changed pretty dramatically. And most of the work that we have done has sort of the aspiration of better models, but we started with better data because we just feel like the conclusions that we'll make are going to be much stronger, first starting with data quality.
Great. Thank you very much, Steve. Would anyone else like to go next? Perfect. I see Colin has their hand raised.
Yeah, thanks. Thanks, Dax. Can you hear me okay?
Yes, we do.
Yeah, thanks very much for the invitation to attend. Yeah, I had to think about this this question earlier on this week. We typically make quite a lot of progress on the supply side of the labour market, particularly for health forecasting, healthcare professional employment, and that's probably for a couple of reasons. Really, one is because we have a sort of natural framework within which to think about future supply of staff. It's just, what we've got at the moment plus inflows minus outflows, and often we'll have, reasonably good data about the supply of staff and those inflows and outflows. So we typically make quite a lot of progress quite quickly. The demand side is just a bit trickier, I think. But at least we have a framework. We've got a sort of framework for thinking about what the determinants of demand for labour are. So we would think about things like costs and productivity and services, and from that framework you can then begin to think about the data that are required to begin to forecast the demand side. But that seems to be a bit trickier. In Scotland, it seems to be a little trickier. So it's quite tricky to pin down what service targets are, and then given those service targets, it's quite tricky unless you're working in a very specific area to sort of work out how to combine various factors of production to deliver those services. So what combination of doctors, nurses and allied health professionals are required to deliver services? And I think that's one of the sort of trickier bits. So we've got a little framework for thinking about the demand side, but trying to get the data to inform that demand side, and in particular the determinants of demand are a bit tricky. I wonder if that's perhaps why there aren't any gold standards. We're just still working on it.
Great, thank you, Colin. That's interesting, right? It's tricky in terms of not necessarily having the data. And so Steve was mentioning starting with good data and using models that are available. And it seems as if perhaps in Scotland, you have the models, you have the frameworks, but the data is just not quite there. Interesting. So I'll open it to anyone else who would like to comment. Perfect, Sarah.
Yeah, thanks, Dax. It is kind of an interesting question. We feel like maybe in health, we might be a little bit behind other industries that are using modeling and forecasting more. And when Cynthia and I were brainstorming about why that might be, we identified 3 things that might contribute to that. The first is system complexity. So the health system is, as Ivy says, often a complex adaptive system. There's lots of variation in service delivery and population needs and the service landscape. And that just makes it trickier to model than who's going to want what product when. Data has come up already. We think that having comprehensive, high quality, granular data that can fit into a model and support forecasting is necessary, but not always possible yet. And the third thing is that the health system seems to be in a constant state of transformation. It's always changing. And so, especially with the pandemic, we've seen a lot of changes. And so it's hard to make a model that keeps up with all of that. And so we think that that's another factor. And I'll just ask Cynthia to elaborate on that from the experience or the perspective of Ontario Health.
Yeah, thanks, Sarah. And good afternoon, everyone. Yeah, to expand on that, around the complexity or the changing landscape, we have seen with the pandemic in Toronto, but I believe Ontario and other areas, we saw there was a lot of, it has led to a lot of physician burnout, closing of clinics, changes in practice patterns in terms of a move toward virtual care, more virtual care as opposed to only in person. We are seeing new models of practice, like increased pharmacy, use of pharmacy to provide primary care. And all these have to be factored in now when you're looking at modeling and what are the right components and targets, as has been said earlier. You know, we have, and all that coupled with increasing complexity of the population, as Sarah has said, we're having an aging population with increasing complexity, patient complexity. And we're also seeing a major impact on social determinants of health, impacting our primary care use. We have an influx of primary care, asylum seekers and new immigrants, many new immigrants coming who may not have providers. So these are not properly captured in the data we have for the need on the need side. And on the supply side, we have also defects in the data that is available in terms of, in Ontario, we rely heavily on the Ontario Health Insurance Plan or HIP data, but we know it misses many of the vulnerable populations. So, and also populations from some primary care practice models like CHCs. So those are some of the challenges that are affecting that. And how the second part was around how close are today's models from estimating reality. We think this may be a bit, it may be difficult to answer at this time. For example, for our primary care forecasting work, which you have been doing with Sarah and team, we would need to look at, to do some retrospective analysis to see how well our predictions or projections or forecasts worked compared to actual data. We are in early stages in this data, data project, so haven't had a chance. We are just going to start looking back and see how well we're doing, how well our projections worked, knowing that there are all these challenges we have just been talking about. So thank you. Yeah.
Thank you very much, Cynthia. So that was great. So, and I think this discussion leads us well into the second question, which is kind of taking things into the next step as to what extent have decision makers been using the prediction from forecasting models to conduct health workforce planning. And so in answering that question, you can also think about what factors or strategies has facilitated their use as well. So as a quick recap, we've talked about how the models are good, they're not quite perfect. There's a lot of kind of intricacies that make them challenging, especially in health. And so now we're going to focus in terms of, are they actually, you know, are these outcomes of these models actually being used by decision makers? Would anyone like to answer first? Steve, you're off the hook.
I'd be happy to start. So as I mentioned before, kind of our foundational primary care needs assessment in the United States that is nationwide as the health professional shortage area. And as I mentioned, the methodologies are really quite stale. But there's a tendency for policymakers to look where the tools are as opposed to where the need is. I think there's the old joke about the guy who lost his wedding band in the dark, and somebody comes along and says, "What are you looking for?" It's like, "Well, I lost my wedding band." And the response of the person is, "Well, I'll help you look. Where did you lose it?" He said, "Over there in the lawn." It's like, "Well, why are you here?" "Well, the light's better." The light is often better for old policy frameworks because there's a standard of longitudinal comparison between health professional shortage areas this year and next. It's a pretty understood methodology, fairly simple, a population provider ratio. But what I think is that we really accepted the light of the data, but it's often in the wrong place. So getting deeper into the data related to social determinants of health and what really drives demand for healthcare systems, breaking away from kind of arbitrary political subdivisions, which is one of the flaws of the current US model. And then thirdly, I think not considering the full scope, a range of clinicians that are involved in primary care delivery. It has changed a lot in the United States. The types of clinicians that deliver healthcare in a primary care setting and how well or poorly those clinicians are working in team-based collaboration at that clinic level.
Perfect. Thank you very much. Would anyone like to answer next? Great. I see Colin lifting his hand.
Yeah, thanks, Dax. Yeah, in answer to the question about to what extent are policymakers or stakeholders using these things, I think in Scotland they are, and I'm pretty sure in the rest of the UK that they are as well. There's recently been a huge public workforce plan published in England on this stuff, which is just full of forecasts, and our policymakers, national policymakers, are very keen on having an evidence base, and we try and provide that to the extent that we can, but also try and make those policymakers and other stakeholders aware of what the shortcomings of some of these things, so what they can do and what they can't do as well. So we use them quite a lot at a national level. They're used in Scotland to inform intakes into nursing and midwifery and medical training and dental training, things like that. So national educational programs, they provide evidence base for that. But I think my own experience from being involved in this process is that it's sort of important to engage with those stakeholders, so not to sort of present these forecasts as the final word on this is a number you're going to have in the future, but more as a sort of a starting point in a process to discuss with stakeholders and sanity check the data, being clear about the methods that we're using, talking about the assumptions that are involved in it, and talking to them about how we can integrate additional data and analyses into the process. So it's not a sort of end in itself. It feels like it's just one part of a sort of broader framework of support for workforce planning in Scotland, at least.
Thanks, Colin. So we see that in Colorado and in the States, maybe the light's not shining in the right place in terms of policy or use of policy or of forecasting for policy and decision making. In Scotland, actually, it's used quite a bit, which is really interesting. Perhaps, Sarah or Cynthia, if we could share your experience in terms of what has been the case in Toronto and in your work. Cynthia, go ahead.
Yeah, thank you. So in Ontario, and I can only talk more about what has happened what is happening in Ontario Health, which is an organization that has combined 23 agencies or previous agencies have come together, and they are tasked by the ministry to help plan and fund and coordinate services, healthcare services in Ontario. There are 6 regions, one of which is Toronto, which is where we are working with Sarah and team. But there are different variations in terms of using forecasting for workforce planning. We see some areas like Cancer Care Ontario, which is very organized and tasked with coordinating cancer services in all of Ontario, in the different regions. And it has been doing some forecasting in terms of looking at estimating FTEs, let's say for oncologists who are required, different types of oncologists required, and how to allocate them in different areas of the province. So I'd say that their work in terms of forecasting is actually being used. For us in Ontario, in Toronto, the work we have been doing with Sarah and team has been focusing on primary care workforce planning. We produced a toolkit, which I believe has been well received and is generally used by our stakeholders, who include, we use it ourselves, some primary care providers, Ontario health teams that are tasked with planning and funding, planning and coordinating primary care in their areas. And the information from the toolkit, which includes some forecasting, has been used. We provide information on areas where there are high needs for primary care and what are the types of resources that may be required. Now, it doesn't always mean that they will get funding, but at least they provide evidence for, for advocating for funding or FTEs in particular areas where there may not be any physicians or allied health professions. So it's a mix. It's a mix of how that information is being used, but I'd say there's some use. Yeah.
Thank you, Cynthia. And considering that Sarah and Cynthia are on the same team project, did you have anything else you'd like to add?
Just very briefly, the extent to which some of those models are used, I think really depends on, comes back to what Steve said about data. And so the stronger the data are and the more the decision makers are conscious of the limitations of the data and the potential power of them, the more likely that these forecasts and models are going to actually be incorporated into decision making.
Agreed. We're coming to the third question, which is my favorite question, which is when we actually get to hear about these fantastic global leaders' ongoing work. And so I've asked each of our panelists to come up with a small presentation, 5 to 12 or so minutes, and to introduce what they're doing locally, and then at the same time answer the following question, which is, in your experience, what was the most useful component of a forecasting model or of its implementation for workforce planning? Do we have a volunteer that would like to present first? And at this point in time, I think, Sheena, if there are slides too, it would be the time to pull them up. So we'll see who would like to go first and then go from there.
Guess I'd be happy to go first again.
All right, Steve, you're...
All right, but I might like the clicker.
Yes, absolutely.
And I might like to stand up.
By all means.
So I'm going to spend just a few moments on the data quality point that I made earlier. Like I said before, if I had the choice between a poor model and excellent data versus excellent models and poor data, I think I would choose better data. And what we really found in order to do better needs modeling in Colorado, we had to start with data quality. This is the first time I've really sort of contemplated the implications of our work on an international scale. So I will admit that this is fairly Colorado-centric. But working in the United States in healthcare policy and workforce research is kind of 50 different versions of health policy because we are so state-driven in some of our work. But one of the things we had recognized is that good quality workforce data was essential to certain statutory functions that we had that were an obligation of my office. I work in government. My obligation is resource allocation, and I feel like it's my responsibility to do resource allocation efficiently. But if the light of the data is in the wrong place, it's really difficult to achieve that goal. Challenges, I am sure, are familiar to everyone in the room. There's lots of governmental authority to collect data on health workforce, but that authority is often locked up in a single use case, purpose-built systems, different data architecture, fulfilling different needs, and it is a rare thing that one of the designers would actually build towards the goal of exchanging and sharing data. And this is not an easy problem to solve. I suspect that change in workforce data is similar in many of the OECD countries, but in Colorado, we know that, for example, about 25% of physician information changes every year, and about 30% of physician affiliations change every year. So that's to say a perfect data set today can be all wrong within a year and almost useless within 2 years. So rather than create a new system, we built a specialized system, and my slides didn't translate perfectly, but that's actually okay because the sources are pretty specific to Colorado, so you don't really need to know what they are. But the notion is rather than build something from scratch, create a new data silo, we would instead try and look at the landscape of data available to us to make use of it. We kind of approach this with the notion that all data is garbage, but most data is quite useful if you have the right strategies to understand it. So the notion is this sort of Swiss cheese model. There's much more whole than there is cheese, but if you layer enough slices of Swiss cheese, you start to develop a pretty comprehensive picture of workforce. And so some of the examples here are federal data sets on the top, licensure, which happens at the state level in the United States and in Colorado, Medicare, which is our federal healthcare program for the elderly, Medicaid, which is our state program for low income. We also looked at other kinds of sources of data. So Schedule II is a US model for opiate prescribing that requires a federal waiver to do that work. There's a data set that had something to tell us. We also have a tool called an all-payer claims database. We have selected some non-traditional sources. We're in the process of adding driver's license data to our data set. And you might think, well, why would you go through the effort of creating a linkage to driver's license data? But it's actually a pretty reliable source of information about where people live. Personal information leaks into our data all the time, but we can't always see it. So we have a privacy concern. We want to make sure that we're not releasing data about clinicians that they don't want released generally, but also it helps create precision so that we're only looking at locations of data that are relevant to the delivery and capacity of primary care. As you might guess, all this data comes in unstructured, unstandardized, and so we go through a pretty standard process of normalization. I know this is quite familiar as a process to you all in the room, but then we sort of reorganize that data. So the data sets often come to us in a jumble of information about flesh and blood clinicians, facilities, health plans. There are about 300 of which in the state of Colorado. And all of these have attributes that are unique to buildings, people, and payers. And so we have to reorganize that data and then create rather complex relationships among them. So one facility, many clinicians, one clinician, one or more facilities. And as I mentioned, we don't really have a system of healthcare in the United States. We have systems at best, and maybe that's saying too much. But there's a lot of complexity. Colorado is not a large state, and we have 300 plus health plans to work with. But the next step of the process is that we have to be able to update that data over time, and it has to be systematized and automatic. We don't have enough staff to keep over 250 fields of data about each individual clinician current. So we pour in new data periodically from each of those sources, and new data replaces old data. In a quick summary, but it's a little more complicated than that, of course, because we need to make sure that the newer data is actually better than the data that it replaces and represents something new. So step one is the normalization that I mentioned. We then standardize that data against a for-profit commercial data broker that helps us make the data cleaner before we introduce it into our data set. We restructure that data, as I mentioned, through those 3 domains, and then we evaluate the data quality, the trust, the age of the data, and it's field by field, not row by row, but field by field, to try and get the best possible information about that clinician. So if the field is missing, we insert. If there's 2 competing pieces of information, we score it to decide which information is most likely to be correct, how many sources corroborate the same information. And then we create that data mosaic. So currently we have 65 million rows of data as inputs into our system from 18 different sources. It resolves down to about 163,000 clinicians, about 35,000 practice locations, and 300 health plans, as I mentioned. It's a lot of effort to get there, but then that allows us to do what we hope is a fairly innovative approach to our analysis. So just for a point of reference, here we are in Ottawa, and there is Colorado. There, we're in the Western United States. One of the advantages of working in Colorado is when you put together a slide deck, your state fits perfectly in the slide. So this is the shape of Colorado. Those of you who are somewhat familiar with our state, you're probably familiar with our resort and ski industry that you'll find on the western half of the state. Resort communities like Aspen and Vail and Breckenridge and Keystone and Steamboat are places that are maybe points of reference for those of you that care about winter sports. There's about 5.9 million people in Colorado. 3.9 million are in that cluster right there around Denver, which is to say that most areas of the state are quite sparsely populated. There are locations in our state with fewer than 2 people per square mile, southeastern corner of the state in particular. The east side of the state is plains. It looks like Wizard of Oz, flat Kansas wheat, Mountain West, and then that urban corridor in the center. So our modeling really had to accommodate lots of different geographies, lots of different population densities, and be responsive to that sort of predictive model, which we have here. So we stratified according to age and sex. One of the innovations is that we wanted to break away from the notion of just a population provider ratio. That's okay, it's a proxy, but we felt we could do better. So we've age and sex stratified. This is our behavioral health model. And we use a data set from the National Survey on Drug Use and Health. So this is Colorado-specific data. And we stratify by age because the age distribution in our state is not consistent. Our resort communities, as you might guess, are much younger than our rural Eastern Plains agricultural communities. We then apply a model called a variable 2-step floating catchment area method. We use census block groups, which are stable geographies of around 600 people. We create a travel boundary around that geography, put a population weighted centroid, which is just a center point inside of each of those geographies. We say this is going to be the standard service area for this particular assessment. This is just kind of an idealized model here. And the travel boundary tends to be between 20 and 60 minutes based on population density. We don't expect people to travel more than 60 minutes for care for behavioral health one direction. But we do this 4,000 times in Colorado, so they overlap over time. This allows us to break away from that geopolitical boundary challenge that I mentioned earlier and generates a map that looks like this. So of course, there's lots of red here. Each of these deciles represent roughly 10% of the state population, but keeping in mind that most of the red you see here are very sparsely populated areas of the state. Why we think that this is a pretty significant improvement is most often we're looking at county boundaries, which is our geopolitical subdivisions. And counties can be quite variable in size and capacity and distribution of resources. So looking a little bit closer, you can see certain areas of the state, which tend to be our population centers, tend to be better resourced. But this is really a supply-demand model, not a provider-patient model. So we predicted demand for behavioral health services in kind of step 1. Supply of services, we aggregate across 5 core behavioral health professions, such as clinical psychology, social work, professional counseling, and psychiatry. And we survey those clinicians to determine you have a license, you have a pulse, are you seeing patients? If you see patients, what proportion of your day is spent in patients? Are you doing other administrative or academic functions? What kinds of patients do you see? Do you see all payers, not just private payers, but also our public payers? So we hope that we've gotten much closer to really a supply-demand model that is modulated by the demand of the population. I zoomed in on Denver here because, again, I think this is one of the strengths of this model, is that it allows us to distinguish, even in small geographic areas, variation in local capacity. So as you can see, the kind of the northeastern quadrant of the city of Denver is very different than kind of the central corridor here. If I, as a resource allocator, have to make a decision about where to invest in new clinical capacity, I might look at some of those regions of the community that are in yellow or orange. This model is the whole population, all people, all clinicians. The next step of this model is to look at subsets of the population who are low wage earning in comparison to those clinicians that provide capacity to those underserved areas. And I've probably gone over time, so I'm going to stop there. And I'd be happy to tell you more about it over lunch or dinner. Thank you.
Thank you very much, Steve. That was fascinating. So we'll switch to the next presenter. So with Sarah and Cynthia, we'll both be presenting this one.
The way this is going to work is that I'll give you an overview of what we've been doing in Toronto, and then Cynthia will tell you a little bit about how it's being used by decision makers. There we go. So just to orient you a little bit, we're talking about Ontario. There are 6 health regions, of which one is the Toronto region. And the Toronto region itself is divided into 14 subregions, and we look, and those 14 subregions are further divided into 158 neighborhoods. And so we look at the neighborhood level, at the subregion level, and the whole region level. When the Toronto region first came to us in 2017, they requested a fit-for-purpose planning process, and we developed one for them. And what it looks like is a series of activities that happen iteratively that include horizon scanning, scenario generation, workforce modeling, and policy analysis. And what we realized is that even though that process is fit for purpose for primary care planning in the city of Toronto, it actually applies just about everywhere, across professions, across sectors. It really does. If you do all of those things and you do it with engagement at the center, then you can do a good job at planning. In the horizon scanning set of activities, we have some tools that can support looking at what's on the horizon, what's in the landscape. We developed a quantitative planning model after a scan for available data. And that model has since evolved to accommodate the data constraints, and we're in the process of expanding it to respond to emerging issues. So we do a lot of things and we model on a lot of different fronts, but what I'm going to tell you about today relates to the 6 steps in planning that we've outlined for stakeholders. So in order for the regular person, a clinician or a primary care leader in Toronto to engage with planning, they need to consider these 6 steps. The first is to understand community characteristics. Then to understand service requirements, then to understand workforce service capacity, to assess the alignment between requirements and capacity, to explore the factors at play, and then to put it all together. And so where modeling and forecasting come in to this is specifically in understanding service requirements. We use the Canadian Institute for Health Information population grouping methodology to estimate service requirements at a neighborhood level. We projected those forward using the City of Toronto growth estimates. And we stratified by different kinds of service. So service provided by comprehensive primary care physicians and by those who are not considered to be comprehensive. And then we provide this to our stakeholders as a base for understanding what kind of service is necessary. And just to be clear, we're talking about visits to a primary care physician here. And the reason our modeling is physician-centric is because that's where the data are. Some of our additional activities relate to how can we take this and expand it to the other providers of primary care. So having modeled service requirements, in this case, starting from a base year of 2016 and looking out to 2026, we then turn our attention to the workforce and we model service capacity. To do that, we look at individual level service capacity for comprehensive primary care physicians in a given neighborhood. Again, the number of visits delivered. We look at that in a base year, and then we adjust for age-related changes in workload. So again, we project forward 2017 to 2026, and we aggregate up to the neighborhood level so that we can compare neighborhood level service requirements with neighborhood level service capacity. And that is the ultimate goal, is to look and see what's the alignment between what we need and what we can deliver. And when we do that, we see that sometimes there's a surplus, sometimes there's a deficit, sometimes there's a surplus that turns into a deficit. And we can look ahead to try and identify where problems might crop up. So this is the kind of, this is the kind of work that forms the foundation of the policy and scenario analyses that we can do with stakeholders in Toronto. So the gap analysis, which is that alignment piece, identifies neighborhoods with large gaps or with growing gaps. And then we can start asking questions about, why are those gaps there? Are they related to population growth? Are they related to decreasing service capacity from physician retirement? What's happening in neighboring neighborhoods? Maybe it's not such a problem to have a big gap in one neighborhood if you have a big surplus next door. Is the neighborhood a high needs neighborhood? So there are lots of socio-demographic factors that are influencing demand for service. And then what resources do we have that can be deployed to address those gaps? We can do various scenario analyses that look at what happens if the characteristics of the population change. So what I've showed you there is just strictly adjustment for growing population. It doesn't actually, it assumes that the population in 2026 is the very same as the population in 2016. But we've done some additional modeling that says, if we have an aging population, what effect on service does that have? If the population needs more mental health visits, what effect does that have? We can also look at the probability of physician retirement and the impact of that. So we have been able to estimate the probability of a given number of physician retirements, and then to quantify the number of visits at risk as related to those potential retirements. So those are the things that we're doing from a modeling and forecasting point of view in Toronto. And now I'm going to turn it over to Cynthia to talk a little bit about how that information is being used by local stakeholders and what impact it's having on planning.
Thanks, Sarah. So the model, the data that you have, or the model that you have seen is currently available online. We have hosted the toolkit on Ontario Community Health Profiles Partnership website, where anybody who is interested in planning in the City of Toronto for primary care can access the data. It's available at neighborhood level, but can also be aggregated to sub-region level, those ones which you saw earlier in the map. We have, I think, about 11 sub-regions. So you can aggregate the information up to there. So we usually, our team at Ontario Health Toronto gets requests from our internal stakeholders, like other teams who are doing planning, as well as external stakeholders in terms of identifying needs. And it may be due to if there's funding that has come up available, what are the high needs areas with respect to primary care. So we take this information and look at all the things that Sarah has talked about, the population characteristics, the service requirements, the service capacity, the gap. And then we can also look at the visits at risk due to retiring physicians, and then identify some neighborhoods that may be at high risk and flag those. And additional data can be used to supplement or to augment that information. To Steve's earlier point, we also have challenges with data and data quality. Sometimes we have dated data. So we encourage, as Sarah said, engagement of local frontline people who are actually on the ground to say they should look at the data and validate the data, because the data may not capture some of the more recent things that are happening, and there may be some explanations about the patterns we are seeing that can't be got from just the data. So it's been very useful for both internal and external requests. It may be sometimes we get requests from maybe developers in the city. Toronto is a fast-growing area, and there may be developers who want to put to do some developments, and they want to include some maybe primary care clinics. They will say what are the type of characteristics and needs for this area, how is the population going to grow and stuff like that. So we use that information. And another area which I touched on before is we have what we call Ontario Health Teams in Ontario. They're the ones that are tasked now with coordinating services in different areas for attributable population. We use sub-regions as proxy for OHTs, and we are working with them to build capacity for workforce planning. And we hope, we've prepared packages of data. We walk them through and walk them through what questions they can answer with the data available, point out what we think are high needs areas. And some have already been using the data for their own purposes to focus in on particular areas that they knew from previous that they want to focus on. So, and again, the data is used in collaboration with frontline engagement and validation. So we hope that the data will be very useful going forward for establishment of primary care networks by the OHTs and general evidence-based planning. And we're in the process of updating the data. So hopefully we can see how products actually compare to previous, the projected data we had in the first phase. Thank you.
Thank you, Cynthia and Sarah. And Colin, if you'd be able to go next.
Yeah, good stuff. Thank you very much. I hope not to bang on for too long, really, because I'm very much enjoying listening to everyone else. It was after Steve's talk, I was very aware that even today I was complaining about the quality of our data, but actually we're very lucky in Scotland because everything's centralised. We have national data sets all over the place. So our workforce data is at a national level. We have the National Health Service, which is a publicly funded health service. So all the data are centralised. So we're very lucky, really, in Scotland. We've got quite a lot of data to play with. The problem we face is trying to forecast employment gaps in the public sector health workforce in the National Health Service. And we need, in order to be able to sort of tailor our policy instruments to fill those gaps, we need to try and identify the size of those gaps at a sort of spatial level, perhaps not quite as at a lower level as some of the other presenters this afternoon, but at a sort of spatial level, at different employers levels, and also at a sort of national level. We need to find out when those gaps are going to appear. That's a sort of temporal aspect, and we need to be able to identify which professional groups are going to be affected by those gaps. That's a sort of occupational aspect to it. So there's sort of three aspects to these sort of spatial, temporal, and occupational aspects to these employment gaps that we need to try and understand. And we do that by forecasting employment and forecasting demand. On the employment side, we're in pretty good shape, really. We've got quite a lot of very detailed individual level data on employees, doctors, nurses, AHPs, number crunchers, people like me. And with that information, we can calculate outflows, how many people are leaving, and inflows, how many people are joining, and as a result, forecast employment in the future. So on the employment side, we're in pretty good shape. On the demand side, because my organisation doesn't really employ healthcare professionals to fix people, we support the education and training of health and social care professionals. We don't really employ anyone, so we don't really have a sense of the demand for healthcare services or how we would satisfy that demand for healthcare services. So that's that sort of production function business I was talking about earlier on. That's to say how you combine these different factors of production, the doctors and the nurses, the AHPs, the technology to deliver healthcare services. So we sort of duck the demand issue a little bit by passing it back to employers. So what we've tried to come up with is a little dashboard where we have what we think is a sort of useful framework, and we do the number crunching on the employment side, and then we hand the dashboard over to the employers, the people who employ these healthcare professionals, and ask them to, if they wouldn't mind, tell us how many people they think they're going to employ each year in the future. And this is the sort of thing that we get out of it. This is for adult nurses, qualified adult nurses at a national level. So this is at sort of Scotland level, and the lower panel just shows the employment and establishment, all in whole-time equivalent or full-time equivalent, I suppose. And the gap between that green and sort of yellowish line is the gap that we're trying to fill. They're vacancies. We're trying to fill those vacancies somehow. And the panel at the top are the inflows and outflows that drive employment. And we can identify people who leave, that's the outflows. We can identify people who've left and then subsequently return. That's the people we call the inflow from returning. We can identify, again, because we're a sort of single jurisdiction funded by the public sector. We're quite lucky. We were able to link up some educational data, again at an individual level, to the employment data. So for nurses and midwives, we're able to look at the inflow from pre-registration education courses into the health service. And finally, we're able, because these are expressed in whole-time equivalent, we can identify the change in whole-time equivalent arising from people who neither enter nor leave, but just change their whole-time equivalent. That's typically people who are approaching retirement. People typically reduce their whole-time equivalent as they approach retirement. So that's for adult nurses, but we've done this. That was for adult nurses at a national level. This is a sort of heat map for the 4 different fields of nursing practice and midwifery, and for each year we try and identify the relative size of the gap that we're facing. It gives us a pretty quick and pretty stark visual of where we think the gaps are and when we think they're going to appear. This is all sort of historical data, but we forecast this stuff, of course, as well. Green's good here. That's pretty good. They're relatively small gaps, but orange is bad and red is pretty bad. So in this case, we had relatively large employment gaps for qualified mental health nurses at a national level. And of course, we do that for at a sort of local level, at a regional level, at a national level, and not just for nursing. We do it for all the occupational groups within NHS Scotland, ranging from administrative services staff, like I suppose like me, number crunchers like me, to medical consultants, really, and everyone in between. So our solution to the problem of trying to forecast these gaps, well, at least the solution that we've come up with so far, is this interactive dashboard that forecasts employment gaps to give people a sense of the size and timing, location, and occupation of those gaps, and it gives us this, what I think is quite a useful evidence-based framework to start discussions with stakeholders, whether that's the employers themselves or whether it's policymakers in the Scottish Government. It allows us to check our data with them and the assumptions that we've made. It allows us to think about additional data and analysis that we might need to develop the evidence base a bit more. It allows us to discuss some unobserved factors, so things that aren't in the forecasting model at the moment that we think might be coming along in the future. There's a sort of tax issue a while ago that was a pretty important one in the UK. And finally, once we've sort of gone through all this process, it provides quite a useful framework within which to tailor policy instruments to particular circumstances. So, for example, if our forecasts identify short-run and local gaps, then perhaps the focus for policy might be on supporting international recruitment. Whereas if we identify relatively long-run and gaps at a national level, then the focus might be on sort of education. And I suppose the other thing that we get out of the other benefit that we find from this process is that we can think about the interaction of those policy instruments. So we can start conducting little scenario planning exercises. What if we're able to grab a few more international recruits and stick them into Edinburgh, for example? What impact will that have relative to increasing the number of adult nurse places on pre-registration courses over the next few years? So we can run those sort of scenario planning exercises. I'm happy to answer any questions, and I'm also happy to have a discussion about providing access to the actual forecasting data. If people are sort of interested and want to talk about it a little bit more, I'm more than happy to talk about making the data and the forecast available to people. Thanks, Dax.
Thank you, Colin. That was very interesting. And I think now we do have a video from Nick Lord with the Australia Health Authority.
Good morning. My name is Peter Hogan and I'm from the Health Workforce Data Intelligence Unit here at the Commonwealth Department of Health in Australia. Unfortunately, the Senior Director of the unit, Maureen McCarty, couldn't join you today, but she's asked me to record this presentation giving you an overview of the latest addition to the Health Workforce and Service Planning tool known as Heads Up. It's called Scenario Planner, and it's a modelling capability that we've developed to assist the government and non-government organisations with health workforce and service planning at a local level. But first, a quick recap on what Heads Up is. Heads Up is a single integrated source of health workforce data that can be used to identify and develop innovative policy options aimed at increasing access to primary health services and maximising the value of investment in the health workforce. It uses several data sets to map the distribution of the GP workforce across Australia. The plan is to expand Heads Up from just GPs to other health workforces, such as nursing, other medical specialties, and allied health. It allows users to view service trends over multiple years, compare different geographical classifications, visualise flows of patients between areas, and filter regions to identify areas of interest. It provides users with granular data to identify gaps in the current GP workforce and undertake detailed planning and analysis. Some of the key features underpinning Heads Up. The first one is the development of GP catchments. GP catchments are a health workforce specific geographical classification that were developed looking at how patients were accessing primary care services, and there's 826 of those across Australia. We use a number of other geographical classifications as well, such as national and state, and then other lot more localised, smaller classifications as well. Along with that, we have a number of point location overlays as well to show where the location of primary care clinics, such as GPs, and then allied health clinics and so forth are as well. As part of the development of Heads Up, we also had to come up with new data methods, and that was to look at, in the first instance, how do we count the number of GPs that we have here in Australia and those delivering primary care services, and also what's their full-time equivalent. So 2 of those methods were developed, and we have method papers on those. Heads Up uses a number of other data sets as well. So not just looking at key workforce metrics that primarily we get from the Medicare data set, but also we look at registration and survey information that we get from the Australian Health Practitioner Regulation Agency, and training data from different training programs, along with key demographic population statistics from the Australian Bureau of Stats. So Scenario Planner is the next phase of the development of Heads Up. So what we have previously done is looking at what has happened, whereas Scenario Planner looks forward and projects over a 25-year period. So we've developed a user interface that sits within the Heads Up tool and is the vehicle for how the GP model and others will be accessed and used. Users will be able to adjust and test inputs for workforce policy options and strategies related to training and distribution. Models will be updated regularly with the latest available data. The GP model that we've got underpinning Scenario Planner at the moment, we've taken a micro-simulation approach to that, and it allows us to look at those different scenarios over a 25-year period. It's been developed at the SA2 level, which is quite granular, quite small, and the reason for that is one of the key requirements was understanding the distribution of workforce. We have had the model reviewed by a university within Australia, and also we have consulted widely with stakeholders on it. The idea is that this model and subsequent models will not be, a snapshot in time and, another 5-10 years later do it again, but rather they'll be regularly updated to provide that ongoing capability. For modelling the GP supply and demand, we took looked at a few different modelling methodologies, such as stock and flow for supply, time series forecasting using current utilisation patterns for demand. Then we decided to go with micro-simulation approach for both demand and supply modelling, which gives us the flexibility to model different policy interventions at a granular level. So what is micro-simulation? It's a modelling technique for simulating a set of data at individual patient or provider level. For each iteration, there's an algorithm of rules or steps to follow based off predetermined probabilities. For example, providers are exited permanently or temporarily based on historical exit rates for that cohort. The benefits of micro-simulation are that modelling at a patient level allows us to factor in individual patient risk factors and comorbidities when simulating the likelihood that a person will have a certain chronic condition. This can then flow on to determine how different individual characteristics can impact interactions with the health system. Modelling at a provider level helps estimate how demographic, behavioural and policy changes might affect individual outcomes and to better understand the effects of current policies. It also provides maximum flexibility for adapting the model to different populations and unique supply and demand scenarios. Here's a high-level overview of how we've broken down the GP modelling work into different modules and how they interact with each other. So there's 3 demand modules. The first is the population and household module, and it models the Australian population at the individual level. It creates a synthetic starting population representing Australian individuals grouped into households. The model then generates the demographic variables for this population in the starting period and models changes to the demographic variables in each projection period. The population growth dynamics are modelled within the microsimulation, including mortality, births, and migration. And this module also includes transitions in households. The health conditions module builds upon the population and household module and simulates the prevalence of each chronic condition at the individual level. It answers the question, how do we expect health condition prevalence to change through to 2050 or that projection period? The health service utilisation model links health condition prevalence to Medicare service usage. So the module estimates GP demand in terms of services, GP FTE and services per capita. This module produces demand estimates from the bottom up based on the patient age, gender and comorbidity profile as produced by the preceding 2 modules. It tries to answer the question, given the model changes in health condition prevalence, how many Medicare services will be demanded? The 3 supply modules, the first one looks at training pipeline and migration. So it estimates training inflow numbers from the supply baseline. The module combines expert judgment with projection techniques to determine the baseline inflow assumptions for each training program. It provides inflow numbers from the training pipeline and international migration. The next module is the workforce and service usage simulation module. The main microsimulation engine that calculates the GP supply of the next 30 years. The GP workforce is simulated using a combination of historically observed statistical distributions, policy setting assumptions, and training inflow assumptions. It uses a starting stock of GPs and simulates workforce supply by location, age, gender, and other characteristics. And lastly, the policy setting module. The simulation module uses the input values from this module, such as the number of training places and training length. The idea is to allow the user to adjust these values and run different scenarios to view the impact on the supply of GPs. Then the supply and demand model outputs are all put together to determine the workforce gap in each region. So I'm now going to provide you a quick, now that I've shown you or given you an overview of Scenario Planner and the model, I just wanted to take you now to the user interface that we've developed to give you a really quick overview / demonstration of the Scenario Planner capability. So here's our user interface. So a user will come in, they have a number of selections that they can make here on the left-hand side. They can add locations. So they can show the map, they can change their classification, they can add states to the model or to their query. They can look at different different modelling measures. So we've got supply, demand, gap, unmet demand, gap. We've got different measures that you can look at. We've got dimensions, model inputs, and historical results as well. So the user has quite a bit of, quite a few selections that they can make, quite a few options to look at. Once they've made those selections here, the panel on this side, on the left-hand side, updates. So this is their baseline. And what you can see here is you can see projections of the supply for Australia and for New South Wales, Northern Territory and Queensland, noting that these are just not actual figures, that we're just using these for demonstration purposes. You can view that as a table. You can view that as a graph, and you can view it also as a heat map. So when all the states are selected and those lower classifications, it can give you a good idea of where the hotspots are. The other capability that Scenario Planner has, not only viewing the baseline, but is actually, as we spoke about before, adjusting and creating a scenario. So a user can come across here to the Adjust Scenario tab, and they can then look at the different model inputs and adjust those accordingly. So for example, they can look at the allocation of training across Australia and change the distribution of it for different areas. So a user just simply clicks on that area. They can then change values. Since this is a percentage, if they put something up in one area, then they need to make a corresponding change in another area. They can apply the change just to that year or to multiple years as well. If they save that, these values change, and when the model is run, the scenario is run, then they will be the new input values upon which the model results come back to you. So once you've made all the changes, both on the supply and the demand side, you can hit your Run Scenario button, and what will happen is in the background that will run. It will take around 5 minutes or so, and when it comes back, you can then compare it against the baseline, you can export it, you can delve further into it. There's lots and lots of things that a user can do. There's definitions that you can look through as well. So every modelling measure and dimension has the corresponding information about what it means. That is a very, very quick overview of Scenario Planner and a very quick update on where we're up to with Heads Up. If you do have any questions about Heads Up, would like to find out more, please just email us at headsup@health.gov.au, and we'd be more than happy to answer any questions that you have. Thank you very much. I hope you found this presentation useful and informative, and thank you very much for your time.
We can give a round of applause to all of our panelists and our presenters. So I think I had a few other questions, but we do have about 10-15 minutes left, and I really want to give a chance for the audience to be able to ask their questions. So we may start there, and then if we have some time left, I can add on to some of those questions. So I think, Ivy, you've been monitoring the chat, and I will leave it to you.
Great, thank you. So yes, there are a couple of questions online. First of all, from Andy, said that given that healthcare delivery is constantly changing and the supply pipeline, especially for doctors, is long, does the panel have a view of what is the meaningful sweet spot for how far out, say in years, we can or should be modeling, forecasting supply against demand? And a related question to that is the value of standardized scenarios like we just saw versus fit for purpose scenarios, in conversation with planners. And Steve, I think you have a unique position in being, having a bit of a decision-making role. So just curious about that. How far out standardized versus fit for purpose scenarios? Thanks.
The floor is to anyone who would like to go first and answer.
Yes, I could respond, but this is purely an intuition-based answer. There's no underlying evidence. I feel like the demand side of the assessment is changing faster than the supply side, the considerations. And I say that it's intuition-based because I think so much has changed through COVID in Colorado and the United States, and the social determinant drivers of health and wellness are becoming more sharp. There's greater economic disparity, racism and classism are a problem everywhere. They're especially a problem in the United States. These are things that I think are driving up demand for health services faster than we can plan for a future workforce. And again, like I said, I couch that in, it's just pure intuition.
Thank you. Sarah?
Thanks. I'm going to give a non-answer answer, which is that I think we should be doing all of the above. So we should be looking short-term, medium-term, and long-term. And the questions that we ask in each time frame might be slightly different, but we should be considering all of them. And same thing for scenarios. I think starting with standardized scenarios makes sense, but then those standardized scenarios, the answer or the results of them often lead to further questions, which then inform fit for purpose scenarios. So I think we should have the capability of doing both.
Great. Anyone online wanting to answer this? Okay, so I'm sure there's lots of other questions, so we can go ahead with, actually, do we have an in-person question? Great, Mary?
Is that on?
Yes.
Okay. My question was, I was thinking about as we get more fine-grained, which is fine, this guy to think about here, but maybe not for GP data, as Sarah was saying, we can get down to neighborhood level. But what are the policy responses to that? Like, you know, in Colorado, or, you know, Colin talked about, you know, you can increase education or you can increase international recruitment, but those things are difficult to, I guess maybe the international recruitment can be very localized. I'm just trying to think about like, what are the policy advantages of getting more fine-grained with our forecasting?
Great question. Anyone like to tackle this one?
I guess I have a thought, but I'd like my colleagues on the Zoom to start if they have something to say.
Cynthia or Colin, any comments?
Forgive me, Doctor, I'm not sure I caught the question, I'm afraid.
So I'll repeat it for you, Colin. So essentially, the question was, as we get with more granular data and the ability to forecast by neighborhood, for example, how does this help influence policymaking and decisions? Did I capture that question well, Mary?
Maybe while Colin's thinking, I can offer some thoughts. Policy responses depend on the scale, because not all levers are available at all scales. And so things like education pipelines, they sort of fit best into a provincial level scale here anyway. When you get down to the more localized level, we're talking about levers like programming, resource deployment, advocacy, access to extra funding to support high needs areas. And I think in terms of some of this forecasting and modeling, this is the first time that local health authorities have ever seen this information, at least in Toronto. And they're saying, wow, we thought that this was the case, but now we know that it's the case because these data are validating what we understood to be happening. And then when they go to make an application or an argument for a specific program or additional funding, having gone through the process of examining the data, looking at various scenarios, forecasting out into the future, it's that much stronger. So I think there's value in taking it down to the local level.
I think Colin also had his hand up.
Yeah, thanks, Dax. Yeah, I think that's absolutely right. Really, I'm not sure how the additional level of data affects policy making, but it supports the evidence base on which policy is made. If nothing else, it allows people to question using some hard facts, anecdotal evidence. So rather than just being in a position where a local authority, for example, might say, well, you know, we need many more resources than those people over there because of this factor, the other factor, and you actually have, if you have that detailed level of information, so very local data, at neighbourhood level, at data zone level in Scotland, with lots of socioeconomic characteristics associated with all those different data zones, then you're in a position to either, you know, support those claims or otherwise. But either way, you have an evidence base on which to develop policy, whether it necessarily changes policy or not. But the evidence base is there. Yeah, and I think that has value. Yeah, that has quite a lot of value.
Thank you, Colin and Cynthia.
Yeah, just to add to Colin and Sarah's answers, I think for us, having neighborhood level data really helps provide evidence at more granular information, because our neighborhood, our population is very diverse, socioeconomically, culturally, in terms of the services available in different neighborhoods. You know, it varies greatly from one neighborhood to another. So if there's a high needs neighborhood that is identified, you could see what type of people are living there. Is it more of immigrants? Are they more new immigrants? Is it people from certain cultures, certain, ethnic groups or racial groups? And that type of information can help tailor the services that you're looking for, or the resources, the primary care providers. We have much variation in terms of prevalence of chronic diseases, senior population. So all that helps to tailor, the resources that are required. And especially as we move towards interprofessional care teams, you need to know which type of, professionals are required for a particular neighborhood. Thanks.
Thank you. Oh, Steve, yeah.
I'll follow up at the end, because I did have something I wanted to mention on this topic. There was a paper published a few months ago in Health Affairs, our health policy journal in the United States. It was fairly critical of the health professional shortage area designation work, and they were really looking at population outcomes as a correlation of the designation. And as I was reading that paper, one of the things that occurred to me is the assessment is not the intervention. If you assess need, that is step one. The intervention is what you do in response to what you've discovered there. So though I have plenty of criticism of the federal HPSA model, I don't know that I would have chosen that particular criticism. One of the hopes of our more granular model is that we can start to look at the experience of access at the community level. So the layer of information that hopefully will be coming in 24 is a claims level analysis that will actually look at the origin of patients, the destination of care, the distance of travel to get to that care. We hope to stratify by payer status. So are they uninsured, publicly insured, or privately insured? Income status, education level, and race and ethnicity. And so the next stage of that map is, this is a map for everybody. This is a map for low-income people. This is a map for various race and ethnic groups. When we see a divergence, is it a divergence that just is happenstance? Or is there something occurring on the ground that's creating specific friction for access? And the ideas that we've thrown around in the office, is it something as simple as public transit? Is there not a bus stop available in this community that is more likely to serve our African-American community in Denver? Is there not enough race and ethnicity concordance with the population? It could be something simple as, like, what are the office hours? So very low income people who experience the highest barriers to care, unfortunately in our country, don't have the same kind of scheduling options that I'm privileged with. And if there aren't opportunities for those individuals to seek care in non-standard office hours, they're not going to get that care. And so that's the kind of the hypothesis finding we hope to do in 24.
Thank you. I think we might have time for another question, or not quite. I think we're at the 3:15, so we might end things here. So another round of applause for our panelists. Thank you very much.